Welcome to the first of 3 podcast episodes sponsored by Abbott on time and range. Today we're going to focus on explaining continuous glucose monitoring to patients in primary care. I'm your host, Dr. Neil Skolnick, Professor of Family and Community Medicine at the Sidney Kimmel Medical College of Thomas Jefferson University, and I am so pleased to have joining us today to share her expertise, Dr. Sarah Weddergreen, PharmD. Dr. Weddergreen is an assistant professor in the Department of Clinical Pharmacology at the Skaggs School of Pharmacy and Pharmaceutical Sciences of the University of Colorado. She's also a clinical pharmacist at the UC Health Lone Tree Primary Care, where she focuses on diabetes medication management, helping clinicians like all of us in primary care get their patients on board with CGM and helping us learn how to help our patients. Welcome, Dr. Weddergreen.
Thanks so much for having me. I'm excited to be here today.
Let's start out with can you give us a general view of what CGM is and the promise of CGM for our patients?
Sure. CGM, or continuous glucose monitoring, is a device that measures blood glucose through a small sensor under the skin. CGM can either be owned by the patient and used on a continuous basis as a personal CGM, or it could be owned by the clinic and used for a short time as professional CGM. There are also some differences between the types of CGM devices. There's a real-time CGM that automatically checks blood glucose periodically, and there's intermittently scanned CGM, where the patient swipes a device to obtain a result. CGM is such a helpful tool for patients as it extends that picture of glycemia beyond that simple finger-stick blood glucose reading and brings it to this comprehensive picture of glycemic control. CGM has shown improvements in time and range, lower glycemic variability, decreased hypoglycemia. These are all big wins for our patients with diabetes.
They really are. It's interesting, Sarah. I know when we were talking earlier, you referred to fingerstick blood sugar as just a snapshot. And I love that analogy because, CGM is a video that is just so much broader. It's like a movie of what's happening compared to looking at a lone picture. And I loved that analogy that you referred to it. It's interesting. CGM, and a lot of us in primary care are familiar that if you give a patient CGM, their A1C will improve, right? Because they get this feedback loop. They know what they're doing. And we've also heard a lot about the relationship between not just A1C and outcomes, but lack of variability and improved outcomes, CGM lack of, or rather a decrease in hypoglycemia. And I think a lot of us in primary care really want to do CGM for all those reasons, but we're a little bit afraid of it because we're afraid it's too complicated. Can you start by helping us know which patients should we consider using CGM for, and any things that, like early on when we're suggesting it to a patient, that we should go over with them?
I can definitely understand that fear of the unknown. So it's good to start by thinking about who would we first recommend this for. There could be a lot of reasons that you would select CGM for your patient. Certainly, patients on multiple injections of insulin per day or on insulin infusions would benefit from use of CGM. There might be many other patients who could also benefit, such as those with unrecognized hypoglycemia or glycemic variability, like we talked about. When we're first getting started with CGM, there is some initial education that I want to make sure we touch on today, just briefly. So getting started with using the device, we have to first set up patients to use the technology. So this includes getting them set up with the device and also either a smartphone or reader, something that will allow them to access that data. You'll then also need to set up and explain any alerts, as well as go over some of the basics of troubleshooting issues that they might see with initial use. This topic is a little beyond what we're going to go into today, but I wanted to make sure it was recognized as an important step in this process.
It's interesting, Sarah. One of the things that, again, from a primary care point of view, when people are hesitant, I've found it really works to talk to a patient about the fact that CGM may help them. And I have been so impressed that patients will go, they'll get a device because it's just a prescription. They can get it at the pharmacy. And then they play with it themselves. And oftentimes they're so excited about it that they come in and they teach me about it. And I say that because for those out there who are a little bit hesitant to dive in, dive in. You will learn to swim once you're in the pool, and our patients can often teach us a lot about it. That said, when our patients, though, bring in their devices and they're all connected, they need our advice about what do you do with it? And we're really going to focus on explaining today the ambulatory glucose profile or AGP and how to explain it to a patient. And again, it can be intimidating. So, can you explain what the ambulatory glucose profile is that we get when we're using the CGM?
Yes, absolutely. Explaining that ambulatory glucose profile to a patient using CGM can definitely be intimidating at first, especially if they've sort of become experts themselves by doing their own digging before even getting to your visit. But I do think this can be done in primary care in that limited amount of time available just by trying to keep things simple. The AGP report is a one-page standardized report that's used to interpret a patient's daily blood glucose patterns. It has 3 different sections or panels of data, and I think of that AGP report as a highlight reel that shows that big picture of glycemia for an individual patient. It's a great tool to facilitate communication both with patients and caregivers, as well as even within that healthcare team. As a pharmacist in the clinic, I also talk with providers in my team about this data and help us to all talk together. There are other more detailed reports available that you could use to dive deeper if you have that time, but knowing time is often limited in primary care, that AGP report is a great place to start and has tons of great information for both you and that patient to review.
So, Sarah, let's dive into the details now. Can you go over some of the data that the AGP report contains and how we should approach it?
Yes, each panel of the report has lots of helpful information, and it's important to look at all 3. So, to start, that top panel contains glucose statistics like average glucose or glucose variability, but it also contains the glucose management indicator or GMI, which is interpreted similarly to an A1C. The top panel also contains a stacked bar, which explains the percentage of time spent in different glucose ranges. Time above range is represented in yellow and indicates blood glucose readings above 180 milligrams per deciliter. This section is then divided into categories of high and very high blood glucose with different targets for each. Time in range is seen in this stacked bar in green and represents time within that range of 70 to 180 milligrams per deciliter. Our ultimate goal is really to maximize the amount of time our patients are in this green zone, with a target for most people of at least 70%. The last category is time in red, which is time below range, representing blood glucose readings less than 70 milligrams per deciliter. Similar to the 2 different hyperglycemia categories, there are also 2 different hypoglycemia categories, one that's less than 70 and one that's less than 54.
Excellent. It's really amazing when you're looking at this with a patient. What I find very helpful is the patient brings their device and we go over it together, and it really pops out at you, and it makes it such a clear, easy way to together go over how someone's doing. Can you go over with us now that middle panel?
The middle panel is the AGP, which is a summary of the patient's blood glucose during the measurement period. It looks like a chart with a wavyish line down the middle surrounded by wider bands. The graphic indicates where the patient's target range is to allow for comparison of the patient's blood glucose to this range. When you view the AGP, you'll see this solid wavy line that indicates the median blood glucose, and it's surrounded by some wider bands. The solid median line goal is to be as flat, narrow, and in range as possible. Surrounding this solid line are those 2 shaded bands, which represent different interquartile ranges. The wider the bands are, the greater the glucose variability the patient has experienced. One limitation of the AGP is that if either hypoglycemia or hyperglycemia was not a consistent trend at a particular time, you probably won't see it on this report. This is where that bottom panel then comes in.
So, Sarah, on this part with the wavy line, is that the part that shows you the glucose measurements over time of day so that we can look at a week at a time or a month of time and perhaps see, wow, at 3 o'clock every day, someone becomes hypoglycemic, and maybe we ask the patient. It turns out they often skip lunch. Is that the sort of thing that this part is helpful for?
Exactly. Yes. The time range is from midnight to midnight, and it captures a summary of data over time. And so that's why it is this wavy line, because people tend to have different habits that influence their glucose throughout the day, things like different snacks or when they exercise. And we can see those trends in this wave.
Yeah, I find it very helpful because sometimes, not always, there's a pattern that's worth feeding back or exploring more. How about the bottom panel?
The bottom panel has the daily report for each day in the measurement period. This is really helpful for looking at those days that are sort of outliers from that middle panel, where these individual days might not be fully captured in that AGP. So, in those daily panels, you can see specific days where hypoglycemia occurred, and this would show as shading below the target range zone. And then you can also see where hyperglycemia specifically occurred as shading above that target zone.
It's fantastic. And as you describe this, I think we get to develop a sense of how this works, that we can look at large spans of time in case there are patterns, or we can drill down to particular days where a patient might say, last Thursday I was hypoglycemic, and we look back and we see that. And over time, we can explain to our patients, when they notice that, they should write down a little note. What happened that day? Was there a reason? And we create this feedback loop that patients are just so intrigued with, because it's one thing when you hear, well, if I eat pie, my sugar goes high, or if I skip a meal, my sugar goes low. We know that theoretically, but wow, when patients see that happens for themselves and see that real in time feedback, uh, it leads to such a wonderful increase in awareness and subsequent change in behavior that I've really seen many people have epiphanies, and us often have epiphanies together when they go over the data. Now that we've gone over the components of AGP, how do you go over that with patients?
Yeah, as you mentioned, Neil, that AGP report gives you so much helpful information to start those conversations from. It's really important to break this process down into more simple steps to explain each of these components to patients, because all that data can be a little bit overwhelming. There are a few different approaches published in the literature with slightly different methods of going over the report. But one simple approach that I like to use is the DATA tool, spelled DATAA, from Isaacs and colleagues. This acronym can be a helpful way to recall each of the key steps, and you can break down the process by going through just one step at a time. Starting off is D, which is download data. The first step is to make sure you have adequate data captured within the AGP report. There could be missing data if a sensor fell off or something along those lines. So for current CGM users, we're looking for a minimum of 70% of 2 weeks of data. Once you confirmed you have enough data, I would start by talking to the patient about what they've observed in the AGP report. This is where you might want to have a pen or marker handy. You can start to mark up that report and indicate a patient's routine, like those meal times, insulin doses, when they exercise, and then start talking through how this influenced the trends they've observed. Throughout this conversation, it's important to focus on what's going well. I can relate to this from my own experience with CGM. The primary care clinic where I practice is starting a professional CGM service, and I recently wore a CGM as a test patient for them. I quickly learned through that process that I can get over focused on that data just like many of our patients can. I would constantly check my readings and was afraid to eat certain foods. And this fear ultimately caused some of my blood sugars to increase. So, being able to have a positive focus as we go through these conversations with patients really is important, because there can be such negativity in looking at all of this data. The next step in our acronym is A, assess safety. This is where you'll find that focus on hypoglycemia by looking at the time below range and the number of hypoglycemic episodes in that top panel. I would also look at the specific days and times where hypoglycemia occurred, which would either be in the daily report in the bottom panel if it's not seen in that AGP in the middle. Next, you'd walk through this with the patient. What did you notice was different at those times your blood sugar was low? Can you recall a specific cause for the event, like taking more insulin at a particular day, skipping a meal? The first step would be correcting hypoglycemia in terms of focus for your medication management adjustments. Next, you'll move to T and our acronym, which is discussion of time and range. This is more of that fun part where we really have that positive conversation. You can look at the top panel data and the AGP report in the middle to guide this portion to see where they are in terms of time and range. And you can dive into what's going well for that patient and give them that support and encouragement to reinforce any positive behaviors that are helping them to have better glycemic control. Maybe their blood glucose is more in range after walking or eating a balanced meal instead of fast food. So this is where I really like to spend more time in the conversation because you do get to have that positivity and encourage them to continue with their positive habits. Just to revisit our acronym in case you're getting lost in the letters here of the DATAA, we're now to those last two A's of data. The next A is areas to improve, which is a focus on hyperglycemia or time above range. When looking at this, I would talk a patient through their observations of what's happening during those times of hyperglycemia. Because like you mentioned, Neil, patients will often see certain foods trigger these higher blood sugar readings for them. I even saw this in my own experience with CGM. I have a sweet tooth and ate some ice cream, and this caused my blood sugar to spike each time. And so I quickly saw that if I swapped out this treat for a healthier snack or other option, my blood sugar remained more steady. Similarly, patients often have some ideas of what they can do to correct these times of hyperglycemia, and so I'd prefer to just start by talking through the solutions they have in mind. The last day and step is action plan. Shared decision making with the patient is crucial here, as this often leads to better adherence and results. When making the action plan, we try to keep it simple, focusing on maybe one or two next steps, and really starting with addressing hypoglycemia first.
Sarah, that is just such a fantastic, practical way to approach the information. It's funny, you're talking about your experience with CGM. I also had done CGM as part of learning. And I'd really encourage all of our listeners out there to, if they can, because you'll learn so much about the process. And I got to tell you, I love the way that you talked about the ice cream and that the patient will figure out maybe the answer is limiting ice cream. And it really is. Wearing that CGM, you realize how it pulls you into being interested in your own results. And to use a term that's popular and I think honest, it enhances patient engagement in their own care. And one of the most challenging things for us as clinicians is to get patients excited about their own care, to really be involved. And CGM just really facilitates that in a way that's very natural, I think. The other thing I love about what you said, it's almost a Zen-like approach. The patient has the answers. And I think you're right. When you go over, and what a wonderfully organized approach you're discussing. When you go over that data in an organized way and you say, what do you think? I love that last day, the action plan you create together. It's a wonderful opportunity to really have that discussion, patient engagement, and come up with answers together. Sarah, any final remarks?
I'd like to just conclude by saying that good glycemic control is so much more than just a good A1C. Time and range is an important indicator that's easily viewed using the AGP report and is a great conversation starter. As you mentioned, Neil, you really can engage the patient in these decisions as we come to solutions together. If you're listening and this was your first time hearing or learning about an AGP report, I would encourage you to explore this topic further and start digging into the data while trying to keep things simple as much as possible.
Sarah, this is so helpful, and I'll just echo your sentiment. If you haven't done it as a clinician, recommend it to a few patients and learn with them. Listen to this podcast, read up on it. There's plenty of additional information. You can visit professional.diabetes.org/time and range for all sorts of information about time and range, as well as the ADA's 2022 standards of care. But really give it a try. It's a lot easier than a lot of people think. Sarah, thank you so much for going over with us such a well-organized approach.
Thanks so much for having me. It was a lot of fun to talk about this.
It really was. And I'd like to thank Abbott for sponsoring this episode. Again, for more information, just go to professional.diabetes.org/time and range. For the American Diabetes Association, I'm Dr. Neil Skolnick. And until next time, stay safe and keep learning.